testing out a new feature today, Dr. Cunio, a polling feature.
What's the new feature?
A polling feature.
Oh, wow.
We don't know how it's going to work. It might ruin the entire program, but probably not. Hopefully not. Okay. And I guess, Tanya, you could probably share your screen. We are live now. Okay. And I should change this to there.
Yes.
Oh, yeah. The polling options just, I don't know if you could share screen and poll at the same time. So I think they all just,
We can just stop sharing screen in the middle and go back and forth.
I'm not sure if questions saved.
Ooh.
Oh yeah, no, they have saved. Yeah, we have to stop sharing screens in between. I wasn't able to add the last one. Oh, the Met one. You told me to ignore anyways. All right, nice. Okay.
Can you hear me?
Yep.
My computer just went blank. Just give me a sec. I'll reboot
No
my
worries.
computer. All right.
All right, nice. You there, Dr. Kern?
Just a few seconds. Here we go. All right. All right.
Bring your chair up here.
Are we ready to start yet, or are we going to go on?
I think we are ready to start.
All right. Well, welcome everybody. It's Friday night, and another interesting week. Well, first of all, welcome, and we have cardiac testing tonight, and we have Rachel back from Toronto, Vancouver. Where are you right now, Rachel?
I'm in Vancouver right now.
Vancouver, great. Well, we're going to get started in a few minutes. Before we get started, any questions or any comments from anybody? Paul, how's your week? Anything new happened?
Yeah, something new happened. I got accepted to medical school at McMaster University.
So I tears in my eyes the other day. So Paul's going to medical school. He's that's fantastic, and I should like a big round of applause for Paul over here. It's great.
Thank you.
That's awesome news.
Is that
Thank you. I'm really excited. Yeah.
I think we're all really excited, and yeah, when you called me up, I was not stunned, happy, just everything in the world, and tears in my eyes. I had to just sort of have a quiet moment there and just feel really good. And so, so Paul's going to be able to do these cardiac testing soon. He'll be able to interpret them. We got lots to talk about tonight, and just trying to think. Is that I guess we'll just go on with the first slide there, Paul. Let's see what we got over there.
Yeah. All right. So we can begin. We have a few pictures at the start to show. Here we go.
So here's the new wardrobe. You can see. So we can see now masks are getting different flashy. Should you wear a mask? And the answer is, at this point in time, the number one reason to wear a mask is to keep people sick, and it actually hides my wrinkles and some of the gray hairs and things. And so one of the things that we're talking about is that well, we're going to do a webinar how to make your own mask in the future, where to get them, and how should they be used. But look at these colorful masks with so many different people and face shield. The world's starting to open up, and how do we social distance? What's your thoughts on how do we social distance well, Paul?
I definitely think one of the most important things is understanding that. Let's see. Yeah, just understanding. You have to respect other people's boundaries as well. A lot of I've noticed a lot of people get a little bit flustered when individuals start coming a little bit close to them, and I think it's a matter of respecting each other's boundaries. Staying home is probably the best thing that we could do to socially distance, but we know that it's maybe not the most realistic to stay home all the time because we still need to get groceries. I'm going to show some pictures later today where I went to get some blood work done today at a lab, and they were very, very strict with their social distancing. No one was allowed to touch any doors besides the staff. No one was allowed to touch anything in the entire office besides the staff, and they're just going around pumping hand sanitizer to everyone as well, which it was very nice, and it was very good to see. They're really taking appropriate measures. So I have those pictures later on in this presentation too.
Yeah, you got to remember is that you can't get blood work done. The best thing you can is make an appointment and check online which ones are open and when. So we had a lot of people who were afraid to get blood work, but after your experience, we'll show some information. Paul will give some thoughts there. So we have these wonderful people here in clinic. So we're starting to see people, and we're trying to be as careful as we can. Again, one time I'm used to a crowded waiting room. If we have more than one person in the waiting room, that's too many. So that's a big change. And so we'll keep moving forward, keep learning, and there's more to life than just isolation. Isolation is very important, but also social distancing and how you bring yourself back into the proper world, doing this safely. I think we have lots to learn, and we're learning more about this. Next slide, please. This is this week. So did anybody weigh themselves this week? I'm up to 174. I gained a little bit of weight this week because here's my lovely wife, Carrie, in the kitchen. She made a vegetarian pizza. I got this big bag of whole wheat flour, so we made our own dough, or she made the own dough. She makes some, and we got the bread machine, and we got whole wheat bread, and boy, it's I got to be careful what I'm eating right now. So lots to work on. So thank you, Carrie. Thank you all for the cooking and the efforts. She said she didn't want her picture on the internet, so there she is. So I could be in trouble. I better not show her that. There you go. And so one of the things is we're going to eat our way out of the virus situation. And so last week, how to eat healthy. So this is a really healthy pizza there, and then whole wheat flour and everything. So what have we learned about the COVID-19? Let's get to the next slide. So that's my dog. I'll bring him over in a sec over here. So it's interesting is that we're learning a lot. We have different phases now of how the virus affects you. So first of all, the virus likes to enter through the nose and through the lung system, and you get this initial viral response. And then you have the body's fights with the immune system. So on the top, you see the blue, the virus starting to win, and then hopefully in the bottom, for most of us, your inflammatory or your body's response to a foreign substance takes over. And some people go through this hyperinflammatory stage, something called a cytokine storm. So some of the things that we're learning about is initially some people can have a lack of oxygen in the bloodstream and not feel too sick. And then some people can get this exaggerated body's immune reaction that has to be toned down. So some of the therapies are going to change in different parts of if you're affected by coronavirus. And some people will have an asymptomatic process, and some people, unfortunately, will have a fulminant and fatal course. And what we learned is that the inflammation plays a role in lots of diseases, such as arthritis and in heart disease as well. So that the process that affects heart disease affects coronavirus as well. So what I learned is lowering my blood pressure, lowering my risk factors, lowering my weight changes outcomes. So this is how we're thinking about COVID-19 at this stage. Next slide, please. And, you know, we just showed you a slide on COVID-19. This is a slide on atherosclerosis. And you know, the problem, the foreign substance in the body is bad cholesterol called LDL and other particles as well. So I'm going to let Rachel and her team take over and talk to us about is that so we can diagnose COVID-19, diagnose heart disease and cardiology. So I was looking at some of the slides that you guys put together, and it looks fantastic. So really looking forward what insights you're going to bring us today. Go ahead.
Great. Hopefully our thing is helpful.
So, Dr. Cooney, you might still want to speak on the next couple slides as well. But
let's go back one more slide. Let's just go back one more time. Let's go back to the other slide about atherosclerosis. So one of the things is that what we got wrong about atherosclerosis, it's not a linear progression. It's not just you gradually get plaque and it gets worse and it builds up. What atherosclerosis is, or a heart attack, is a rupture of a plaque, a volcano erupting, and you know, predicting a plaque rupture is really impossible at this stage of the game. So you can have a very small amount of plaque and rupture that and have a large heart attack. And so, but we can stack the odds in your favor. So lowering your blood pressure, lowering your weight, don't smoke. If you smoke, it's a good day to stop or to slow down. Good day to know your blood pressure. Good day to go on a diet. It's a good day to monitor your diabetes. I don't know how to change your family history yet. You can't change genes yet, but you know that so if heart disease is in your family, you have a higher risk. Next slide, please. So Paul and I were privileged to hear one of the world's expert. I think he's the world's best expert. His name is Dr. Rob Hegley. He's Canadian. He's from London, Ontario, and he gave a really amazing talk last night about new insights into heart disease management. And some of the things he brought out is that if you do get, and there's a lot of interaction between heart disease and COVID-19, unfortunately, the risk factors that unfortunately leads to people passing away with COVID-19 are mostly the same risk factors that affect heart disease. So as you get older, you're likely to have heart disease and have the ill consequences of COVID-19. But young people can have heart disease too as well, and young people can do badly with COVID-19. And we know when you're infected with COVID-19, about 25 to 30% of people will have some myocardial damage. And so we have to understand that the heart's affected by inflammation and the heart's affected by normal risk factors. Next slide, please. This is a very interesting slide about what an electron micrograph of what COVID-19 looks like. On the bottom is you see something called rosuvastatin or Crestor. Now, there is some early data that people who take Crestor or rosuvastatin, that specific medication, may provide some protection against COVID-19. That's the case. But it's certainly good to see that one of the medications that make you live longer in cholesterol may protect against heart disease. What's that noise we're hearing in the background there, Paul?
It might have been typing.
Okay. All right. So it's always good to type and take notes and things of that nature. That's good. So, and another good reason to be on cholesterol medications is it might be helpful against the virus. And right now, the only cholesterol pill that's helpful for the virus is Crestor rosuvastatin. So I take 40 milligrams most days of my life, and sometimes a little bit more. I take between Lipitor and Crestor. Right now, the edge is towards Crestor as protection against heart disease and COVID-19. Next slide, please. Now, we'll always have to worry about drug interactions. We're getting into antiviral therapy, so I'm not going to get too specific about this, but as time goes on, we're going to have to be looking into interactions. So what I want everybody to realize is you should know what you're taking. I keep hearing statements, well, it's the same as last time. You should know. The answer is that we should all know, we should all interact together to know what's going on. So at some point in time, we might have to worry about antivirals. So this just talks about one of the antivirals right now that there's no interactions, others will be interactions. So, we're learning a lot about how to fight this virus, and we'll see what happens. Next slide, please. We also know a lot about how to fight heart disease and detect heart disease. So today is, I got up early, I went for a bike ride this morning, and I plan to do another 100 kilometers this weekend. Now, so to me is that you have to decide what you're going to do for activity-wise. I think I do activity for my mental health as well as my physical health, and also to fight that immune system and to make it stronger. So everybody has to find their own inner space and find ways of protecting yourselves. I'm fearful. I see a lot of people saying, yeah, but no, I'm not taking the next step. So take the next step. If it's going to be a walk today, if it's going to be get out your bread machine, make a cheeseless pizza, going out and socializing distantly with friends and colleagues. I think these meetings are extremely important to the group that comes here. I feel bad for the people who don't. There's so much to learn, so much to share. It's about community. It's about working together. Most of us are incapable of really conquering the world on our own. We need each other, and this is a great time. And one of the things I've been privileged is to be able to do cardiovascular testing, and Rachel and Tammy and her team are going to explain a few things about what to look for. So I'll be quiet again for just a moment. Who's going first?
I am.
Paul's going first. All right.
All right. So here's a quick breakdown of the things that we're going to talk about today. So as you see, we're going to talk about a lot of the tests that we hear very often, like stress tests and echocardiograms, but even some might be a little bit more intimidating, like angiograms later on in the presentation. So we'll begin with a little bit of an introduction. So this is a very obvious question, but there's a lot more depth to it than meets the eye. Why do we do testing? Obviously the first thing that comes to mind is to figure out about a diagnosis or about a certain condition. But again, there's a lot more that comes to the eye, and I'm going to look at this from a medical or scientific perspective. This is what goes on in the minds of the doctors when we prescribe tests. If you just hit the next button. So you notice here we have the probability of diagnosis. It could be about any particular condition. Let's say it's about heart failure. There's a 0% chance of having heart failure to a 100% chance. Then you have these two regions called the test threshold and the treatment threshold. So when you're below the test threshold, it means that your chances of having this disease, let's say heart failure, are so low that we can almost be sure that we don't even need to test for it. It'd be like someone who's completely healthy would fall into this first region there. And therefore, we don't need to do any testing because it would just be a useless or a waste of the resources if we know they're healthy. On the other hand, there's the group that we know for sure have this disease.
Welcome.
Hi there. So on the other hand, there's a group that we know for sure would have this disease. And again, this is the group that's above this treatment threshold. In this group, we don't need to do testing because we know they have heart failure, and now we have to start treating heart failure. However, if you look in the middle, you could just hit one more time, Tanya. If you look in the middle, there's this huge region where there's a lot of uncertainty. We don't know if you have heart disease yet, and we don't know if we should be treating you. We need to make sure of that diagnosis before we begin treating you, and that's why we do testing. It's to move to either below the test threshold or above the treatment threshold. And it's to bring some certainty into your condition. So if we can move on to the next slide. We do have a little bit of a disclaimer for this talk. Rachel brought up this really good point. So we're going to be talking about a lot of different tests that we use at clinic. And the goal of the presentation is to help you understand why we do particular tests. So again, it's a great opportunity to get to know your health better. And just hit next there, Tanya. However, it is going to be really easy for many of us to start thinking, whoa, I might need this test and this test. We had a list of 9 tests on the first page. Maybe I should go get every single one of those 9 done. That's just the nature of how we work. However, we do want you to know that Dr. Cunyu and the clinic provides routine testing when necessary. If you are due for a test, we are going to schedule one. If you have a particular concern, such as chest pain, you can express what your concern is first to Dr. Cunyu, and then he'll decide when the test might be necessary as well. So it's instead of just self-diagnosing or self-prescribing these tests, keep it in the hands of the doctor and express your concerns. And if it has been a really long time since you had any testing and you know you're at risk, then just remind Dr. Cunyu. It's been 3 years since I last had a stress test or something of that type, and you might be due for some routine checking. So again, this disclaimer is just to remind you that while it's important to know about testing, it's also important that we don't over test all of us. And the reason for that is, if you just go on to the next slide there. The reason for that is because there's this whole campaign in North America, especially, called Choosing Wisely. And here we have a few points. I'm not going to really dive into them, but the idea of choosing wisely is that there's only so many resources. There's a limited amount of resources, and we have to spend them wisely in healthcare. Pretend healthcare, we don't even have to pretend. Healthcare does have a budget, and we have to make sure that we're budgeting wisely and we're not using resources where we don't need to as well. So that's just the idea where we don't want to overprescribe or over test as well. So if you do have any concerns, bring them up with Dr. Cunyu. However, trust Dr. Cunyu's word when he says, you don't really need a test yet versus you might be due for the test. So then we can start talking about the test. And the first one we are going to talk about is perhaps the most common or the most casual, blood pressure. And we hear about blood pressure all the time, so we're going to talk a little bit about that, as well as how we take blood pressure. All right, so blood pressure tells us about the pressure against the walls of your arteries. So it's the pressure of your blood against the walls of your arteries. And high blood pressure can actually damage the arteries and lead to things such as aneurysms, heart failure, heart attacks, and strokes. So we have to be careful about high blood pressure, which is one of the reasons why we monitor blood pressure. However, on the flip side as well, we also have to be careful about low blood pressure. And this is because it can cause symptoms such as lightheadedness, nausea, fatigue, and syncope or fainting. So blood pressure, you can think of, there's this idea in science called homeostasis. And essentially it means you're finding a balance. Your body finds a balance to maintain itself. And so with blood pressure, it's important to find that balance, and we want to avoid the high and avoid the low. So here we have, the typical blood pressure we see, that 120/80 with a heartbeat of 60. And just for context, that first number there is what we call the systolic blood pressure. That's the blood pressure against the walls of your arteries when your heart is contracting. The diastolic is when your heart is relaxed, and the heart rate there is just your pulse, so how many times your heart beats per second. Okay, so if you have issues with high or low blood pressure, it is recommended to purchase and frequently use a blood pressure monitor. We can't stress this enough, especially in times like this with COVID-19. We are trying to reduce the amount of blood pressures we're taking in clinic just to adhere with social distancing rules where possible. And so if that's the case, if you do have a problem with high or low blood pressure, it is recommended to take it frequently. And I do want to bring up this one interesting point. A lot of us are used to going to a doctor's office. Sorry, excuse that.
So a lot of people get their blood pressure.
A lot of us are used to.
Go ahead. Yep.
A lot of us are used to going to a doctor's office and having a blood pressure reading done there. But I do want to emphasize that that might not be the most reliable reading. And the reason for that is I have made a couple of graphs here. Just hit next time, yeah. So let's say you go to the doctor's office every 4 months or every 3 months, and you notice every time you go to the doctor's office, your blood pressure is high. You're not checking your blood pressure at home though, so that's the only information we have to follow. If that's the case, we would be treating you as if you had high blood pressure. However, let's say you decided to buy a blood pressure monitor and you go home and check your blood pressure. And you find out that at home, your blood pressure is perfectly fine. It's in that low range, and you see you have a lot of values there. You're checking it every single day. It's only in the doctor's office that your blood pressure is high. This is actually a phenomenon called white coat hypertension. And it does exist and it does happen, but it just goes to show how important it is to make you check your blood pressure at home and keep track of that. I did also just post on YouTube another video on how to keep track of your health. So be sure to check that out if you are interested in.
I'm going to pause for a second. That video that Paul made and his team is phenomenal. It contains so many good clinical pros. So that's a good, really fine information on how to monitor your health. So I think we posted it on Wednesday. Is that right?
Yeah, it was just a couple of days ago. It
is fantastic. It's one of those things that's a must video for those who monitor their health at home. And great job. So please go back to it. It tells you about from laboratory to monitoring blood pressure and other risk factors. And Paul, another home run. So I'm going to go back and look into it again. I've already listened to it twice, and everybody should listen to that a couple times. Remember that we got to look at things more than once. If you can remember everything you read, good for you. Most of us forget most things, and we need to go back and refresh our memories and keep learning little bits and pieces. And that's the beauty about this. These things are all recorded. You can go back, fast forward some parts, rewind some other parts, and do different parts. I know Rachel likes to go at supersonic speeds when she looks through some of the things. If I go really fast, then I slow down and just ponder and rewind about 5-6 times and just to pause and think about things. Go ahead there, Paul. So again, people really get sometimes really upset because the blood pressure is really high. Means you're human. The blood pressure goes up, and there's certain ways of measuring blood pressure we're going to talk about. So it's all the blood pressure readings, as Paul's mentioning. Go ahead there, Paul.
Yeah. So again, it's important to take your blood pressure at home for the reasons we just discussed. And like I mentioned, it might be worthwhile to watch that video that I discussed before. I am going to tell you how to take your blood pressure at home in this video as well, just because. Again, as you mentioned, we are trying to reduce the amount of blood pressures we're taking in clinic. So try to take your blood pressure at least 3 times a week. However, if you have perhaps more severe condition and your blood pressure is something you have to pay more close attention to, you can try taking it twice a day. So that's in the morning and in the evening. And checking your blood pressure is actually different than what we're typically used to. And it's quite funny because a lot of us will think, you check your blood pressure, you just check it once. In reality, checking your blood pressure actually means taking it 3 times in a row in one sitting. And then you're actually going to discard that first reading and you're going to average the second and third reading. So here we have an example. And you do the same thing with heart rate. But, you have 3 readings. So let's say I'm checking my blood pressure. I have 3 readings. I'm going to get rid of that first reading, and then I'm going to average the second and third reading. And so my final blood pressure, when I check it this one time, is going to be 132/77 with a heart rate of 73. So every time you check your blood pressure, be sure to check it 3 times and discard the first one, average 2 and 3. The reason for that is because the first one can be, or quite often, frequently, is a little bit off, and the more you check it, the lower patients tend to see it go. So number 2 and 3 are the ones that we look for as well. Okay. Now we have some do's and don'ts of taking your blood pressure. So don't smoke, drink coffee, exercise, or bathe 30 minutes prior to your measurements. And try not to talk during your measurements. I know a lot of us are very conversation heavy and love to discuss. We'll be sitting across our family and take your blood pressure on the couch while we're in the middle of a conversation. But, spare yourself a couple minutes just to take your blood pressure to make sure it's as accurate as possible. Try not to talk during that measurement. Ensure the cuff isn't too loose. A lot of us actually put the cuff overly loose. So you want to be able to fit just 2 fingers under your cuff. So it should be tight enough to be able to fit 2 fingers, but not loose enough that it could fit any more than that. Make sure that the tube isn't twisted and make sure it's not stuck under something. And again, like we mentioned before, don't include that first reading in your average as well. We have some do's of blood pressure monitoring though. So if you just hit, oh, looks like Tanya might have disconnected for a second.
Yeah, so it's kind of interesting when you measure blood pressure. Again, there's a natural change in blood pressure. In fact, if your blood pressure is always the same, you're probably about to die because blood pressure goes up and down, and that's the natural state of blood pressure. So,
All right. Yeah, and we're back. Okay, so some do's though. Be seated for at least 5 minutes prior to your blood pressure reading. So you obviously don't want to go on a run and then run up the stairs and then take your blood pressure immediately. Give yourself a little bit of time to relax. Sit in a chair with your feet flat on the ground and your arms supported at around chest height, or heart height is what a lot of organizations call it as well. And then if you take your blood pressure readings in the morning, I know this is something that a lot of patients have confusion on. Take your blood pressure readings in the morning. This is typically also done before your medications. Be sure you write down whether you've had your medications or not. Because if you have high blood pressure without your medications, that's probably expected, and that's the reason why you are on blood pressure medications. However, that is different than having high blood pressure without your medications, or having high blood pressure on your medications, because that might mean that your medications might need to be adjusted. And then last but not least, as mentioned before, take your blood pressure 3 times and average the second and third reading.
So one of the worst times to measure your blood pressure is when you're on the phone talking to Dr. Curnew. I had a patient today. Well, I didn't do it, but my wife's taking my blood pressure now as we're talking. I said, well, that's maybe not the best time to take your blood pressure. And I understand. We all have to take it at different times. Better to have it then than never at all. But other times to also measure is I think my blood pressure is too low. Measure it. Find out.
Yeah.
Or I think it's too high. Measure it. But people who feel their blood pressure can't really feel their blood pressure. So that's been actually tested quite well in studies. So the only way to know your blood pressure is to measure it. And most of us should have a blood pressure machine in the house.
And I have this very quick video from Omron Health. It's about a minute, and it's just gonna show us how to take your blood pressure once more.
To get an accurate reading, it's important to take your blood pressure correctly. One of the most important factors in taking accurate blood pressure is having a proper fitting cuff. Once you have the right cuff size, find a quiet environment and rest for 15 minutes. Sit in a chair with your feet flat on the floor and your back straight. Rest your arm on the table with your palm facing upward. The cuff should be level with your heart. Do not talk or move while taking a measurement. Avoid food, alcohol, exercise, smoking, and bathing for 30 minutes prior to taking a measurement. Your blood pressure can naturally fluctuate throughout the day, so taking it at the same time each day will give you more accurate comparisons. For tips on making changes to your lifestyle to lower your blood pressure, visit Omron.
Yep, and so blood pressure is something we do very frequently at clinic, and we do a lot at home. And the reason why we do it a lot is because there are certain things that we look out for as well. So here are some blood pressure conditions that we see often. Hypertension just means high blood pressure. Hypotension means low blood pressure, and these have the effects we described before, where hypotension can lead to fainting, but hypertension can damage the arteries. I mentioned there's something called white coat hypertension, and this is why it's crucial to check your blood pressure at home, because some people have high blood pressure in clinical settings, but normal or low blood pressure at home as well. So we don't want to be treating you with blood pressure medications if you have normal blood pressure at home, because that increases your risk of falling into that low blood pressure range. And then this one is new to me. Rachel actually just introduced this one to us. Masked hypertension. I didn't know about this, but some people have low or normal blood pressure in clinical settings and can have high blood pressure at home as well. And these are the people who should be treated but aren't being treated because it looks normal to us in clinic. And last but not least, there's nocturnal hypertension. So typically, blood pressure follows this very interesting pattern. So, blood pressure is usually higher in the day and lower at night. However, for some individuals, blood pressure can be higher at night and during the day. And this is something that we do need to treat as well. And if any of these do occur and where there is concern, we issue what's called a 24-hour blood pressure monitor that looks at the averages during the day and at the night. So it's this little patch that you can wear for 24 hours. You bring it back to clinic and we check your averages during that time. And so that's most of what we need to talk about for blood pressure. We can move on to the next test.
So just remember, is blood pressure, it's not one number, it's the totality of all your blood pressures, those are done at home during your testing, in the clinic, and sometimes that 24-hour blood pressure machine gives tremendous insight. So, it's really important to do it properly and well. Thanks, Paul. Let's hear about the lab tests.
All right, and Tanya, I'm just going to take over for this part.
Yeah, can you hear me?
Yeah.
Yeah, okay, perfect. All right, so like everyone knows, when you come to clinic, the first thing we do at the front desk is give you a requisition to get some blood testing done. And a lot of you may know about the things that we're talking about, but we'll tell you what the important things that we look for in your blood tests are. So a blood test is a really neat way to just take an overall snapshot of your overall health. It gives you values that you can use to look at the condition of some of your organs. And it's especially important to monitor how your body responds when you're changing certain medications. So the few that we look at in clinic are cholesterol, your LDL, your HDL, your triglycerides, your EGFR, your ALT, and creatinine, and the HbA1c. I'll get into detail about all of these in a second. So just before I get into the testing, what is cholesterol? We know that cholesterol is a type of fat that's found in our body, and it's important for your cells. It's important for normal bodily functions. But when there's too much cholesterol in your blood, it's going to start collecting in the artery wall, in the walls of your arteries. It's going to start narrowing your arteries so that your blood isn't flowing properly to the different parts of your body. So this is especially a problem when it starts happening in your heart. So you've got these tiny arteries supplying your heart. And when you start to get plaque buildup in these arteries, you're narrowing the blood flow to a really important organ. And eventually you're going to completely block off the blood flow, and that's going to lead to heart attacks. So you want to avoid excess cholesterol in your blood. And normally we do that by prescription of statins and other things that we'll get into soon. So cholesterol, the total cholesterol that we look at it's recommended to be less than 5, but if you're at risk for a cardiac event or if you have other comorbidities like hypertension, obesity, or other things that put you at risk for anything cardiac related, your cholesterol should be lower than 3 or as low as possible. Cholesterol is broken up into, there's 3 different kinds of fat that contribute to your cholesterol levels. The first one I'll talk about is LDL. So LDL is considered the bad cholesterol. It's the main component that contributes to the plaque buildup in your vessel walls. So we want this one to be as low as possible. It's recommended to be 2 millimolar, less than 2, but as I mentioned for cholesterol, as low as possible is good. HDL is considered...
LDL means lousy cholesterol.
Lousy, yes. You want it to be low and lousy. And then we've got the HDL. This is the good cholesterol. So it's thought to absorb bad cholesterol from your blood vessels and take it back to your liver to get absorbed. So it kind of cleans up your arteries, and you want this one to be higher than about 1 in your blood report. So these are two values that will mainly only change if you're taking your medications properly.
So what do you think? I think you have H for healthy cholesterol and L for lousy cholesterol. So those are some numbers I keep in my brain if that's helpful.
Mm-hmm. Yeah, exactly. So these values will, again, as I mentioned, only change if you're taking your medications properly. So if your LDL is nice and low consistently, and all of a sudden you stop taking your medications and it goes up in your blood values, we'll know exactly why. It's because you've stopped taking your medication. So you have to stay careful. You have to stay committed to your statins and make sure you're taking medications regularly. The last component of cholesterol is called triglycerides. It's another type of fat in your body that's highly influenced by lifestyle. You want to make sure your triglycerides are less than 2. And as I mentioned, they're highly influenced by lifestyle. So if you're eating fatty foods, if you're eating a lot of oily things, or if you're just drinking a lot of alcohol, alcohol plays a big role in triglycerides. If you're having any of these too much, your triglycerides will increase drastically. So triglycerides are one of the fats that will actually fluctuate very easily. So, and there's actually one of the easier ones to control with your lifestyle. So if your triglycerides are high, the first step you should take is to start eating a bit healthier, exercising a bit more, and completely cutting out alcohol. So some other lab tests that we look at. The first one I'll talk about is the hemoglobin A1C. So this is a measure of the sugar that's attached to your blood cells. It estimates an average of 2 or 3 months of blood sugar. This is the one we mainly look at to diagnose people with diabetes. So an HbA1c of 5.7 to 6.4 is considered to be in a pre-diabetes range, while 6.5 or more for two or more tests is considered to be diabetes. Another one we look at is ALT. So this is an enzyme that's found in the liver, and it usually stays in the liver. But if your liver isn't functioning properly, you're going to have an increase in ALT in your blood. So it can suggest liver damage if your ALT is starting to increase in your blood. Generally, an ALT of 40 is considered high. Another one we look at is creatinine. It's a waste product that's made from our muscles, and it's cleared out by the kidneys. So usually we won't be seeing this in the blood if your kidneys are working all right. But if we start to see it in your blood, if we start to see it in your blood, it's because your kidneys aren't doing a good job of filtering it out. The healthy range varies based on age, gender, and race. Another one that we look at is EGFR. So this is a measure of kidney function. EGFR, it goes down as kidney function worsens, and an EGFR of less than 60 suggests that some kidney damage has occurred. And the last one that we look at is potassium. This is a very important electrolyte for the body, and it's involved in muscle and body function, and it plays a big role in for the rhythm of your heart. So the normal range is usually 3.5 to 5, and we keep a close eye on it, especially if you're on some medications. Okay. Some other lab tests that you may have heard about. The first one is troponin. The troponin is a molecule that's found in your heart muscle, and it's usually not going to be in the blood. It only shows up in the blood when you have heart damage, usually from a heart attack or some sort of injury. So if you're having a troponin test done, it's only going to be because you've gone to the emergency for chest pain, for some other sort of injury where they suspect that you may have heart damage.
So you want to be smart about if you're in the emergency room, ask the doctor, what was my troponin value? And write that down with your highest troponin value. That just gives us an idea how much heart damage has taken place.
Mm-hmm.
Yeah, Tanya. Great.
All right. Another one that we look at in clinic is called proBNP. So this is a hormone that's secreted by the heart. And the more that your heart stretches, the more that the walls of your heart have to stretch, the higher amount of hormone is secreted. So that means there's more pressure on the heart. This is a test that you have to pay for, and usually Dr. Creaney recommends it if we think that you may have heart failure, or if we think you may have heart failure.
So heart failure is when your heart's not pumping well enough, you get short of breath, or our heart is pumping at a higher pressure. So there's a great webinar that was put together on heart failure. Just take a look at that. So you can see lots of things to think about. Thank you, Tamia. Go ahead.
So this is Paul's pictures.
Yeah, so I like I mentioned earlier, I went to a lab today to get some blood work done, and I just had a little story to share. I was absolutely shocked and impressed with how the labs are looking now. So this is one lab. They asked me not to say the name, even though I'm sure the green gives it away. But this is one lab in near my house that's normally very, very busy. Normally the lines are out the door and there's people lined up at the door. There's probably 50 people waiting at a time. So you can see, the labs are quite empty now. They are open and they are available to do testing, but they're empty and they're taking very strict social distancing measures to make sure everyone who comes in for a lab test is staying safe. They have chairs 6 feet apart. No one is allowed to touch any of the doors. No one's allowed to move any of the chairs except for the staff. So the staff gives you hand sanitizer as you come in, hand sanitizer as you come out. And they make sure that, you don't have to touch anything that could put you in danger as well. So I do know a lot of patients are a little bit hesitant in getting their blood work done. So I did want to post these pictures so that you could see what the labs look like, and they are trying their best to be as safe as possible as well.
All right, so just a little note, we take charge of your own health. You are able to access your blood reports from websites like Life Labs or DynaCare. You just need, I believe, a code that comes with your blood work that you're given when you hand in your blood work. Actually, I think it's just your health card number, right, Paul?
Sorry, for DynaCare Plus, you do need a code. I believe Life Labs is your healthcare.
Yeah, okay, so that's how it works. So if you are interested in looking at your blood work, it's a good way to keep track of it. The Life Labs account, it works great. You can go back in the past and look at all the blood works that you've had done. So if you are able to do that, please do so.
I think that's wonderful. I think everybody should consider this option to know where they stand, and this should be the norm rather than the exception. I'm seeing more and more people do that. So I really thank those labs for making that available.
Mm-hmm. Yeah.
Now, I don't have access to that bit of your lab work that way. We use a different system called OLIS that allows us to search multiple labs to find things. It's not perfect, but that works a whole lot better than it did 10 years ago. So great inroads about that. But you should know your results, and that's the best way for you to do that.
All right. So the next test that we'll be discussing with you is called the electrocardiogram, the ECG. And most of you have had this test done when you've come to clinic. It's the test you usually take right after having your blood pressure taken at clinic. So an ECG, what is an ECG? So the heart, the muscles in your heart move in sync through an electrical current that passes through the heart. And ECG is able to monitor and look at these currents going through your heart. There's two components of the heart that we can actually look at. The first one would be the structural component, for which we have another test, and then the electrocardiogram is really important to look at the electrical component of the heart, to look at any rhythm abnormalities. So we're mainly looking for rhythm problems in your heart. So if you're having palpitations, or if people who have atrial fibrillation, we can see those kinds of conditions on your ECG. However, it can be difficult to catch palpitations or irregular beats on an ECG because it only takes a 10-second window of your heart rate. So in the case where you have palpitations or things like that, then we have other testing called a Holter, which we'll discuss shortly. So what to expect when you're coming in for an ECG. So ECG leads are placed all over your chest. So you will be asked to expose your chest. So it's best if you wear a clothes that you can easily take off or unbutton. This is a note for the men in the audience. So rarely we may need to shave off parts of your chest hair just to get a better placement of ECG leads. So just sometimes you can expect that. And for women, if you can avoid putting on lotion or sunscreen on your chest, that would make it easier to place the leads as well. And the last thing is just take a little rest. So you get to lie down for a couple of minutes while the test is being done. And that's all it is. So I'm going to pass it on to Rachel.
So the ECG has actually been around for a while now. It can also tell if there's some heart damage, as well as you mentioned the rhythm problem. So it's a very valuable test. it's a simple test. It's not a perfect test, but it's most cardiologists, before you see them, will have an ECG done on you, and I find that invaluable. What to do now with this COVID-19 situation, we'll have to make individual decisions about when to do that. But in the past, it was, a very much done very frequently. I think we're going to do a lot less of them at this point in time, but I look forward to a time where we can get back to doing more of them. Thank you. That's wonderful. So now I got my blood work done, I got my ECG done, I got my blood pressure done. What's next?
All right, so now we're going to talk about Holter monitors. Some of you may have heard about this test before. This is basically a little machine that you carry around with you for either 24 hours, 48 hours, or sometimes we may prescribe it for up to 3 days, so 72 hours. And what's different from it than ECG is that it takes a much longer period of time, and it monitors your heart for a much longer period of time. All right, Tanya, next slide, please.
So one of the things to monitor is we're now actually going up to 2 weeks right now. So that's, it's evolving. So anywhere between 24 hours to 2 weeks is sort of the upper range at this stage. And so a little bit, everything's changing. Far away. Go ahead.
Okay. So there are two main types of monitors. The most often one that we use is continuous monitoring monitor. So that's the little machine that you see on the right of your screen there. You have leads, multiple leads that are put on your chest, and you carry that machine around. By continuous monitoring, it means that it is taking an ECG every single second while it is attached to you. So whenever you have an event, we would be able to see it. If you feel something and you note down the time that you felt it, we can go back to the records and we can see what type of heart rhythm you were in when you felt faint, when you felt you had a little pounding in your chest, when you felt like you had chest pain. We'll be able to rewind back to the time and see what your heart was doing. The other type of monitor is called event monitoring. So this typically comes in the form of basically a giant Band-Aid. So you can do this remotely. This giant Band-Aid can be shipped to your house. You pick it up, and then it's very easy to put on. You put it on exactly like a Band-Aid on your chest. And what this does is that it will only turn on if your heart is doing something abnormal or if you trigger it manually. So unlike the continuous monitoring Holter monitor, it doesn't always take your ECG. So that means if your heart isn't doing anything abnormal and you seem to feel something, if you don't trigger the monitor yourself, we might not be able to catch it. So these are the two different types of monitors, and there are different indications for why we would choose one over the other. There are different categories, I would say, reasons of why a doctor might choose for a Holter monitor to put on the patient. One, it might be because you have an irregular or an abnormal heart rhythm, such as atrial fibrillation, and the doctor needs to make sure that either your medications are working, or if you're on a pacemaker, we want to make sure that your pacemaker is working properly throughout the day. And that's when we would put a Holter monitor on you so that we can see everything is going well, your heart rate isn't too fast, your pacemaker is working, and your rhythm or irregular rhythm is under control. The second type of reason is trying to get to the bottom of things. So if you're telling Dr. Kearney, I'm getting dizzy a lot, or I'm having fainting spells, or you have lots of palpitations, irregular sensations in your chest, like fluttering or pounding, and you're getting a lot of these, but you don't know what's happening, Dr. Kearney might put a Holter monitor on you, just so whenever you do feel these symptoms next time, we're able to look at the ECG recordings on the machine and see what your heart was doing when you were feeling those things. So then that's the second type of reason, where we're trying to get to the bottom of things, trying to make a diagnosis or draw a correlation between your symptoms and your heart. And the third type of reason is we're trying to determine whether we should treat you or not. So you might have a lot of extra heartbeats that we can see on your ECG or that you can feel, or you might have done a Holter monitor before in the past. And we just want to monitor or keep track of how many of those extra heartbeats you have, or how many episodes of irregular rhythm do you have throughout the day or throughout the week. If you have a lot of these and they seem to be causing you a lot of problems, or if it looks like the pattern on your Holter monitor is a bit of a high risk pattern, then the doctor might decide to give you some medications or give you some other treatments to keep it under control and keep your risk under control. The third type of reason why we do Holter monitors is we're trying to see if we should treat you or not. And the fourth type of reason is to help clarify your prognosis. This probably isn't too often seen at the clinic, because it's usually after you have a heart event. For example, you just had a heart attack and your doctor wants to know, okay, did this heart attack affect how your heart rhythm is going to function? So that's when you might be put on a Holter monitor so that you can get monitored for a few days or for a few weeks to make sure that after the heart attack, your heart is still functioning normally and still able to keep a normal rhythm. And it'll help clarify your prognosis or how well you will do, and it'll help to clarify any therapy that you should be on in case your heart was damaged. All right, so next slide. So after we went through all the reasons for doing a Holter monitor, there's got to be information that we can get back so that we can answer the questions that we just asked. So the information that Holter monitor gives includes your baseline heart rhythm. So most people's baseline heart rhythm would be what we call normal sinus rhythm. It's a normal rhythm that everyone has. Some people's baseline heart rhythm might be atrial fibrillation, where it's an irregular heart rhythm. And sometimes we don't know what the baseline heart rhythm is, and that's why we're doing a Holter monitor, and that's going to tell us if you are in atrial fibrillation. Now, the second type of information a Holter monitor can give us is it can count the number of extra heartbeats that you have. And this can range from a few extra heartbeats to thousands of heartbeats. And there isn't really a tight number in how many is too much. And it'll really depend on your doctor and him knowing your clinical situation, knowing your other health problems to be able to determine how many heartbeats is a little too much for you, or if you have what we call a high burden of extra heartbeats. The next type of information that Holter monitors can give is, as we said, it'll be able to tell us whether your medications for your pacemakers are working as they should be. So for people with atrial fibrillation, often their heartbeat can go too fast. It can go up to 100 beats per minute, almost 150 beats per minute, 200 beats per minute. And they're often given medications to make sure that their heart rate is controlled at a reasonable rate. And a Holter monitor will be able to make sure that not just at the clinic, but throughout the day, their heart rate is able to be controlled by their medications. Similarly, if you're on a pacemaker and it's supposed to pace you when your heart rate is too slow, and you want to make sure that pacemaker is working, then you may be put on a Holter monitor and for a period of time to make sure that when your heart rate does drop, that pacemaker kicks in as it should be. And the next type of information that we can get is any short or long pauses in your heart rhythm. So some people normally everyone tends to have a bit of a pause when we are sleeping or early in the morning when we're just getting up. That's normal because as we're sleeping, the sympathetic tone is lowered and we're just in a relaxed state. Our heart rate naturally lowers when we're sleeping. So we can have pauses like 1 second pauses, 2 second pauses. That's all normal. But when the pauses become too long, when it reaches like 5, 6 seconds, that's when people start to faint and start to lose consciousness. And that's when we try to intervene or make sure that you're doing okay with these pauses. We might also get worried if these pauses happen when it's not at night. So maybe when you're walking up the stairs and you have a sudden pause, that's not supposed to happen because your heart rate is supposed to increase when you're exercising. And so when you have the monitor on, we can tell when these pauses are happening and how long they are. And the doctor can use this information to determine if you should be given something like a pacemaker to help make sure your heart rate is beating at a reasonable rate. Next, we can detect any irregular rhythms that occur, such as atrial fibrillation. Now, a lot of you may know that people can't feel their atrial fibrillation, which is helpful because then you can know how often it happens throughout the day. But the majority of people who have atrial fibrillation can't feel it. So they have no idea how often during the day that this atrial fibrillation kicks in. And the longer you are in atrial fibrillation, the more at risk you are at getting a stroke. So we want to make sure that we're catching these atrial fibrillation episodes and treating them adequately so that we can lower your risk of getting a stroke. All right, so to answer our question about whether your symptoms are related to your heart, so you might be getting sensations where your heart is fluttering or your heart is pounding, but that might not be from your heart. It might be spasms from your chest muscles. It might be spasms from your chest muscles. That's the most common reason other than your heart. So when you have this monitor on, whenever you have a symptom, as long as you note it down and you write down the time that you had your symptom, we can go back to the record and we can check what your heart was doing. And if your heart was just beating normally all throughout when you had this pounding sensation, that makes it unlikely that it's your heart that's causing your symptoms. And it tells the doctor that maybe we should be looking at something else. But on the other hand, if we do see that your heart is beating abnormally when you're getting chest pains, when you're getting dizzy, or when you're getting palpitations, then that might be an indication to the doctor that maybe we should be treating or giving you some medications to help you control the abnormal beats and to help you control your symptoms. Next.
All right. We have one question from YouTube, from Thelma. Is occasional fluttering a common occurrence and not a cause for concern?
Does Dr. Kuhn want to speak on that before I speak?
Sure. But I think it means that you're alive. Your heart should go up and down. There's a thing called heart rate variability. If your heart beat's always the same, you're either very boring. Your heart should go from first gear to fifth gear. So it's actually a very, very important concept is the heart goes up and down. And is my heart beating in an abnormal way? Is that many people's perception that the heart's fluttering when the heartbeats are actually normal. It's good to know. There's different patterns. So yes, normal, and 90% of us have extra heartbeats. I have extra heartbeats, and so do 90% of you, I hope.
Yes. So yeah, I think occasional fluttering is fine, but if you're finding that it's bothering you to the point that you're having them every day, multiple times a day, and you really can't tolerate it anymore, that's when we might put a Holter monitor on you just to get to the bottom of things and make sure that it is your heart and that we can do something about it.
There are different heartbeats. Something called premature atrial contraction coming from the small chambers of the heart tend to be less serious, and PVCs or premature ventricular contractions come from the bigger chambers, and they could be sometimes a marker for damage to the heart, things to worry about. So a horse bucks and jumps, your heart is electrical, it should give off extra heartbeats. So we can figure that out together if yours is a normal, a worrisome, or just a benign condition. So very valuable.
Yes, that's the last point in terms of the information a Holter gives. It can help us determine if you're at risk of future heart events, such as like a ventricular tachycardia, where you have just really fast heartbeat and your heart really cannot push blood adequately. So when you have a lot of irregular heartbeats, and when those irregular heartbeats look a certain way, it may signal to your doctor that, okay, there's a chance that these might degrade into a more dangerous heart rate. and that's when we would try and treat you.
You got to be a little bit detective yourself. So if you notice your palpitations when you're watching a scary movie, that's good. More people are likely to feel their heart fluttering at nighttime when you relax. The warning ones that worry the most is that you're sitting there minding your own business, and then you collapse without warning. That's called syncope, and that is a very worrisome thing. Getting up quickly and dizzy, that means you're human most of the time. Just get up slower. So the things that worry you feel that you're going to die, you feel impending doom. Exertionally related symptoms are more worrisome. So if you're running for the bus and you collapse, you have a family history of multiple people collapsing or sudden deaths in the family, or sudden loss of consciousness without warning, those are very worrisome findings, and those really require prompt and immediate evaluation.
All right, and before we move on to echoes, I just want to butt in here to remind everyone, this might seem like a lot of information, but it's recorded on YouTube, and you can come back to it and rewatch it as many times as you need. And we are encouraging questions, so if anyone has any further questions, you can message in the YouTube chat box or in WebEx as well.
So one of the questions about extra heartbeats, look at the company it's going to keep. And so I think we're going to talk about echo and see if your heart muscle is strong or weak, or what's next about that. So that's actually a very important concept. I'm interested in hearing about echoes.
All right, so we'll get into echocardiogram. So an echocardiogram shows us the structure of your heart. So we've talked about the electrical components with the ECG and Holter. And the next important part that we want to make sure that we're keeping an eye on if you have cardiac risk factors is the structure of your heart. It's the graphic outline of the heart's movements. And you can look at the walls of the heart. You can look at the different chambers of the heart, and you can very clearly, well, sometimes clearly see the valves of the heart as well. So who would need an echo? Generally, people who have had a cardiac event or recently or in the past, or who are at a risk of a cardiac event, will be getting their echoes done regularly, yearly. If you have other conditions like a leaky valve or anything that's been more consistently throughout your lifetime, you will also be having echoes done frequently, like as maximum 6 months, every 6 months or once every year.
So it really depends. It's very much an individual decision when to get these done. This is a marvelous tool to look at, as you mentioned, the structure of the heart, looking at the heart muscle and the valves and the lining of the heart sac too as well. So I'm still in love with these things 30 years later. Tomorrow there's going to be another echo course. There's so much to learn about echo. 30 years later, we're getting better at understanding the heart. There's still much more to discover about this. And so the danger is we can do too many if we're not careful, but we need to learn how to use this technology well. So let's keep learning. Go ahead there, Tamia.
All right. So the things that we look at in an echo specifically are to look at the motion of the walls of your heart. So these would be the sides of your heart that we're looking at. We're trying to see if they're moving properly. If there's any part that's not moving well, it could suggest that there's been damage, either because of a heart attack or just because of weakening of your heart muscle. We're also looking at your valves. So these little things that are flapping about, we're making sure to see if there's no calcium buildup or they're not leaking and hardening because of, due to age, you end up having calcium buildup on your valves. And other risk factors can also cause this. So we want to make sure it's not getting too bad, or we're keeping an eye on it if you already have stenosis or hardening of your valves. And the final thing, one important thing that we look at is hypertrophy. So this is a fancy word for saying thickening of your heart muscles. So I just put up a comparison here to look at how the muscle is on this echocardiogram versus over here. So you can see how it's not moving as well, because once your heart thickens, it's not able to contract as well. It's not going to be able to push out blood as well into your body. So you're going to feel more lethargic, or you can feel tired or out of breath. And it's usually because of a continuous stress on your heart. Did you want to add something to that, Dr. Kearney?
I think it's remarkable. I think we understood the we call the systolic contraction, or the heart, how it thickens and it contracts blood out. A normal amount of ejection fraction, a normal person, 55% or greater of the volume of the blood will be ejected at each heartbeat. So normal ejection fraction is about 55%. One of the things we mentioned is that, are you in bad shape or not? One is if your ejection fraction, the amount of blood that's not pumped, your heart doesn't pump properly, the pump is broken, let's say from a heart attack, an ejection fraction less than 20% is a very serious condition with a much higher mortality. And so if your ejection fraction is less than 40%, we have some medications to try to make the heart stronger. So it really tells us a fair bit of information. You also mentioned about hypertrophy or thickening of the heart. If the heart has to pump against a greater resistance because of high blood pressure, for instance, or because you're overweight, the heart just actually thickens and tires out. It works overtime. The other neat part of the heart is that we're understanding we have systole, where the heart contracts. Now we have the relaxation phase, which is called diastole. So 2/3 of your time is spent in relaxation. And we now discovered that's a very active phase, and we can actually look inside the pressure of the heart. One of the neat things about echo is that we use some physics properties called Doppler techniques, so we can actually look at how the heart relaxes and what the pressure inside the heart might be as well. So truly remarkable tool, and that's just been discovered. When I first started off, echo was just a straight line. Now it's evolved to things like strain and other parameters. So there's so much here to learn, and it's evolved tremendously. So bottom line is, the person who reads the echo has to spend a lot of time keeping up to date about this and learning about this. And so this is a marvelous tool. Use it at the right time. So it tells us about the thickness of the heart, the valves, the damage to the heart, and how the heart relaxes. So it's a great tool.
Exactly. So another test that some people get done is a chest X-ray. So we don't usually do or order chest X-rays from the clinic, but if you've gone to the hospital again for chest pain or something, if you've gone to the emergency room for chest pain, then you will likely have a chest X-ray. So the difference is the chest X-ray is static, so it's just one picture, whereas the echo is dynamic. You saw earlier how it showed the heart beating. So a chest X-ray might show you if the heart was enlarged, but it can't really detect anything about the motion of the heart or any specific structural defects. They're more commonly used to look at lung conditions such as fluid buildup or infection in the lungs.
So radiologists use a lot of chest X-rays to look at the lungs. We get some interpretation of the heart on a chest X-ray, but we get a lot more meaningful information by more detailed assessments, such as an echocardiogram. But one of the reasons you go to the emergency room, you're not sure why you're feeling sick, you're short of breath. Is it pneumonia? Is it a COPD exacerbation? Is it a heart condition? And the chest X-ray is a very valuable bit of information for emergency rooms and things like that. If you think you have a pneumonia, you don't need an echo, you need a chest X-ray, and probably some antibiotics and a good physical exam. So it certainly has its role.
Mm-hmm. So I think that's all we have to talk about for the echocardiograms. Next, we'll hand it over to Paul to talk about spirometries.
Yeah, so I'm going to butt back in here to talk a little bit about spirometries. Some of you may have done spirometries in the past. It's a very quick and easy breathing test that tells us a lot of valuable information about your lungs. And, did you know that the heart and lungs are actually very, very related? And we're going to explore this relationship a little bit more. So a little bit about spirometries. As I mentioned, a spirometry is tell me if you could just hit next. The spirometry is a breathing test, and it tells us about the function of your lungs and also the status of your airways as well. Essentially, what you have to do, you get this tube, you put the tube in your mouth, you take a deep breath in and blast it out as hard as you can. You keep going, keep going, keep going, and do it about 3 times. So we are actually reducing, probably not going to do any spirometries anytime soon in clinic, just given the whole COVID situation. We don't want to be releasing all of those respiratory droplets. But for any of you that might have done this in the past, this might ring a bell. So there are two main things that we look at or look for in spirometry. One is called obstruction, and the other is called restriction. Obstruction tells us about how clear the path of your airways are. So is there a clear path of airflow into and out of your lungs? Restriction, on the other hand, tells us how much air your lungs can hold. Can your lungs hold as much as we expect them to, or are they reduced in the amount of air that they can hold? So we can explore both of these a little bit more. So essentially here, once more, we can see on the left there, that's what spirometry sort of looks like. You're given this tube and you have to blow really hard into it. So that's the end that you see. The end that we see on the, us sitting on the computer is to the right there. We get two graphs. One of the graphs tells us about airflow and the other tells us about volume. And we also get this nice, neat little chart here that gives us a lot of information. So let's explore a little bit into that chart as well. You just hit next, Sanya. We have FVC is one of the values on the chart. And you see we have FVC, FEV1, as well as one thing on the bottom there we call the ratio. So FVC is forced vital capacity. And it tells us how much air your lungs can hold. It tells us in liters, how many liters of air your lungs hold. So when this number is lowered, it means that your lungs are holding less air than we expect them to or want them to, and it tells us about restriction, which is, again, basically that your lungs aren't holding the volume that's predicted. FEV1 is forced expiratory volume within 1 second, and it tells us how much air you can force out of your body in 1 second. So if you were to breathe in and take a really hard breath out, it tells us how much air moves in that 1 second. So FEV1 is something that we pay attention to sometimes, and that's because low FEV1 can be a predictor of mortality in some cases. So it can predict death, and it makes sense if you're not able to move air out of your body when you need it. It can be a predictor of mortality. There is this one last value there called the ratio. We call it the ratio. It's actually FEV1 over FVC. And I want to put this into perspective a little bit, why the ratio is important. So this ratio tells us, it's a ratio of how much you can force out in 1 second compared to how much you can hold in total. The reason why the ratio is really important is because it compares, if someone is only able to hold, let's say X amount of air in their lungs, and their FEV1 is low because they're only able to hold that much air, it essentially compares the FEV1 to the FVC. So there's different meanings when your FVC is high and your FEV1 is low compared to when both your FEV1 and FVC is low. So it gives us more of a comparison between the two, and this ratio would tell us about obstruction. So a little bit more about obstruction. We say obstruction, but it's commonly known as chronic obstructive pulmonary disease or disorder, or COPD. And it's the reduced flow of air through the airways due to damage. So if you look at this image here, a lot of us, or some of us might have experienced acute bronchitis at some point, but there are others who have chronic bronchitis. And bronchitis is an inflammatory condition. It's going to really lower or constrict the airways, and there's going to be a lot of mucus and that builds up in the airways as well, as you can see there. On the other hand, if some of us have been smoking for a very long time, we can damage our lungs, and this can lead to something called emphysema. Now, your lungs are actually very elastic. They're like rubber bands. When you breathe in, you're stretching the rubber band, and when you breathe out, you let go of that rubber band, and all the air comes pushing out as well. So in emphysema, smoking may have damaged the rubber bands, and that leads or causes the airways to collapse as well. So there's this one analogy that I like to think of, and consider yourself driving on a highway. There's a lot of traffic. You have 6 lanes. The traffic's flowing very, very smooth. However, I like to compare obstruction to construction that's happening on the side of the road, and they're closing off lanes, right? So let's say they close off 3 lanes, and now all of the cars that were supposed to go through 6 lanes are now being forced through only 3 lanes, and it really backs things up. Air is just not moving, not as much air is getting through as you want it to. So that's one way that I like to think of obstruction. It's like, lanes in your lungs, or just space in your airways have been reduced.
That's what smoking does.
Yeah, and that's what smoking does, exactly. So I'm getting to the most predominant cause. The vast majority of obstruction is caused predominantly by smoking. Smoking, like I mentioned, directly damages the lungs, and that's why it's very, very important to cut back on the smoking as well. There are some less common causes. Occasionally, air irritants and pollutants, or chemical fumes, or dust as well, can cause obstruction, but it is predominantly smoking. That is the major thing, and we want to make sure that we have those airways open, we have those lanes open on the highway so that air can move, and that's why we encourage the cessation of smoking as well. Restriction, on the other hand, is something else that we can find from the spirometry. Again, this is when we have a reduced ability of your lungs to hold air. And this means that your lungs aren't being used to their full capacity. Let's say a healthy lung can hold, for example, 4 to 5 liters. If we do a spirometry and we find that your lungs are only able to hold 3 liters, it means that there is some amount of restriction there, and they're not able to hold the amount that we would predict them to. So restriction is frequently caused by things such as interstitial lung disease or pulmonary fibrosis. Obesity is often a cause of restriction. So you can imagine if there's a lot of weight on your torso, it can really push down the lungs, and it's a lot harder to fill the lungs up with more air. And so obesity is often a cause of restriction. There are some pleural diseases like effusion as well, and some neurological diseases like diaphragm paralysis that can cause restriction. Finally, lung surgery can cause restriction. So some of us might have some conditions that might require a lobe to be removed, for example. Obviously, if you have a piece of your lobe missing, it's not going to be able to hold as much air as if you had your whole lung there. And so lung surgeries or lobe removals can also cause restriction. And you might be wondering, we're talking a lot about the lungs, but the lungs, as I mentioned at the beginning of the spirometry section, are very, very important and related to the heart. The lungs bring oxygen into the system or into the body, and then it transfers into the blood. And then the heart is responsible for pumping the blood around. And so we do breathing tests for a few reasons in our clinic. One is to determine, or a lot of patients will come in with symptoms of shortness of breath. And one of the reasons we do spirometry is to determine whether the shortness of breath is due to perhaps damage within the lungs, or whether it might be due to heart-related reasons such as congestive heart failure. And again, Dr. Cooney mentioned earlier, there's a video on congestive heart failure. So if you are interested, you can watch that in for more detail. Also, severe COPD can lead to death as well. End-stage COPD is a very, very severe condition. And so, we are interested in the care of our patients and making sure that our patients are surviving. So, and we do track or monitor COPD as well, cardiovascular system. And not a lot of people know this. Smoking can increase your blood pressure, can increase your cholesterol, and have various effects on your cardiovascular system. So not only by smoking are you damaging your lungs, you are directly damaging your cardiovascular system as well. And finally, high blood pressure in the lungs, and this is related to what Tanya said earlier. High blood pressure in the lungs or in the arteries around the lungs affects the heart because, like Dr. Cooney said, if there's a lot of blood pressure, it can cause hypertrophy or an increase in the muscles of your heart, and this can ultimately have adverse effects as well. So again, with all that said, spirometry is something we do look for in our clinic because smoking is something that we do see quite often as well. So we would recommend, I think Dr. Cooney mentions this a lot, every cigarette is 5 minutes off of your lifespan as well. So We do have a lot of resources for smoking cessation. We have some videos on that, and if you are interested in quitting smoking, please reach out for some support if you need as well.
So the thing about the lungs as well is that people get short of breath from all combinations of factors. And looking at the lungs, one of the most popular parts I find about the spirometry is what's your lung age. So you're 40 years of age, but you're either overweight, you smoke. Your lung age is that is somewhere over the age of 80. So really understanding the concept of how lungs fit into the overall system as well. One of the major problems is that if your chest wall is too big, you're overweight, it really compresses your lungs. If the muscles aren't strong, you're deconditioned. Your lungs can't expand, and that affects the lung function as well. So it's a simple test, but it's a very important test. And to make the diagnosis of COPD is you need to have spirometry, and the respirologists now are taking a big tool of their weapons right now. Is that we're going to do a lot less spirometry for a while, and then once we'll get back to this, we'll get back to measuring that. So important piece of information to know how your lungs are doing.
Right. So the next test that we're going to look at is stress test. I'm sure this is a test that a lot of us here are familiar with. And the stress test is very important because it checks how the heart responds to stressful stimuli. For example, I found this one comic and I thought it was just very, very fitting right now, given the current circumstances. This is Dr. Kearney right here asking his patients if he's ready for a stress test. Turns on the news, and of course, what more stressful thing could he be watching right now than the news? We're constantly getting updates about COVID-19 and world events, and we do tend to watch more news than is healthy for us. So I thought this was a nice little funny cartoon to show. So we could just move on to the next slide there. All right. So the stress test. The stress test measures the heart's response to bodily stress via physical activity. There are also options for drug-induced stress as well. And during the stress test, typically we measure blood pressure, heart rate, ECG, and sometimes breathing while on a treadmill. And so it's very useful for detecting ECG changes. So if you remember back to Tanmia's talk about ECGs and also Rachel's talk about Holter monitors, you do have an ECG on you while you're doing a stress test. And I think Dr. Kearney and both Rachel mentioned exertion is very, very important if you notice symptoms during exertion. So that's exactly what the stress test focuses on. It exerts you and it looks for if there's any detectable changes. So we can look for ECG changes that might indicate ischemia. Now, ischemia is damage to the heart or blocked arteries. So ischemia is just another way, for your sake, of at least saying damage due to blood isn't reaching certain aspects of the heart. And we can also look for palpitations or irregular rhythms as well. Now, for physical activity on the stress test, we have a treadmill in our clinic. That's what we use for stress tests. And it's very convenient in that, it's in the same location as your appointments, and we have the test results immediately. You can have a stress test and then follow up with Dr. Kearney right after to see your results. However, for some individuals that aren't able to use a treadmill, for example, if there's very, very severe arthritis, they're not able to walk on their own, or they're not able to walk on a treadmill, there are options for bikes. So the bikes we do have to refer out to an external location, and then we'd have to wait for the results, so you wouldn't be able to get these immediately compared to the treadmill. And there's also the drug-induced option as well in cases where perhaps people aren't able to use a bike either. Okay. Now I have one question for everyone. What is a MET? Anyone want to try answering this?
Is that a food there?
Is it a food? Some people might think it's slang that young kids are using now. Anyone want to try giving this a shot? What is a MET? some of us might have heard this. Okay.
I think it was a measurement of horsepower, but let's hear what the number is at 3.5 cc's per kilogram per oxygen uptake per hour. It's a measurement of work done. Go ahead, Paul. Explain that
Sure.
in English.
I'm not going to talk. Yeah, I'm going to explain it in English and not the numbers. So if you just head to the next slide there. A MET is known as a metabolic equivalent. So it's just a short form for a metabolic equivalent. And it describes the intensity of an exercise. And by that, I mean, it actually compares how much energy your body is using when you're doing an exercise compared to how much how much energy your body is using when you're at rest. So you can imagine if I'm just laying down in my bed, I have my arms spread and I'm staring at my ceiling, just living my best life. My body is not using very much energy. However, if I go for a run, my body is using a lot more energy. So it's going to compare the energy while I'm running to the energy I use when I'm just at rest. And
so when you're just at rest, that's 1 MET.
Yeah. And so I have some examples to show as well. But the maximum METs tells us about your functional capacity. So, how fit is your body? How much is your body able to move and exercise? Is some information we get from maximum METs. So fewer METs, one reason that I'm talking about METs in the stress test section is because, again, we have you on a treadmill and we have you exerting yourself. However, fewer METs can make the stress test less reliable because your body is under less physical stress and less exertion. Since the heart experiences lower stress, it might not have symptoms that it would experience during times of high stress. So if you imagine, I'm going to use an example of shoveling. It's very commonly known that shoveling is a hotspot for heart attacks to happen. Individuals might be outside shoveling their driveways, and they might be doing a very high intensity exercise. And that's when some of these events or some of these symptoms might occur. However, at the same time, if an individual comes to our clinic and does a stress test and they aren't really exerting themselves, there are very few METs. If 1 MET is at rest, so let's say they're only doing 3 or 4 METs, that's just a brisk walk. We can't tell the same information that we would get from someone doing high METs. And so here we have some examples. We have some at-home activities and some formal exercise. So for reference, 1 MET is when you're at rest. So all of you sitting at home right now are exerting around 1 MET. So sweeping the carpet is about 3.3 METs, whereas vigorous playing with kids or moving furniture at home is something that is a lot more than 6 METs. If we start looking at formal exercise, very brisk walking at around 5 or 6 kilometers per hour is 5 METs. Weightlifting is 6 METs, and going for a run is 11 METs, and it is going to increase more the faster you pick up that pace as well. So you can see METs is a ratio between how much energy you're exerting and what your energy is when you're at rest. In a stress test, we try to look, or a reliable stress test occurs at the high METs because your body is in a lot of stress and a lot of exertion, and this is where, if we were to see any symptoms, we would expect to see them at these high intensity exercise. So we could just go to that next slide there. And so here we have some target MET values or estimated values of METs. And this was a chart that Dr. Creaney sent a couple of days ago. So for a lot of us, let's look at the 50 to 59 or 60s. A high or good or average METs is 7 to 9 for the 50 to 59 age, and then 6 to 8 for above 60s. But then you can also see for women and men as well, there is the good and high value as well. So, if you are, next time you do a stress test, you can ask what your METs are, and you can see where you sort of fall, because this also tells us about your functional capacity, how fit your body. If you're in the average, good or high, it means that, your body's averagely fit or better than average in terms of fitness as well.
So to me, this is actually a very important number. This determines what happens to you. So people who can go greater than 9 to 12 METs on a stress test, that means their horsepower is very good and they have a good prognosis from the heart. You can lack blood supply to the heart, but if you can go over 12 METs, the chance of you dropping dead from heart disease over the next year or two is quite low. You need about 5 METs to be able to function at home, such as doing some shopping, going to groceries. If you can't do 5 METs, it's going to be normal function. So what happens when you get sick, you lose your reserves. So let's say you start off at 5 METs and you're able to do that. All of a sudden you get sick, you pneumonia, you've been in the hospital for 2 weeks. You lost 25% of your cardiac reserves and you're down to 3 METs. You can't go home. You have to go to a retirement setting. You have to go to rehab because you're just not able to, make your bed, do your grocery shopping. So that's why getting fit and being fit is so important. So you start off at 12 METs, you get sick, you're down to 10 METs. You can still beat up on your next door neighbor and things of that nature. You're still in good shape. So please work on your fitness. And there's actually some data for every 1 MET increase in activity by improving your fitness, your mortality from heart disease falls by about 10%. So you can easily increase your fitness by 3 METs. And that translates to potential reduction in mortality by 30%. So here we are in an era where your cardiovascular health is important for your heart and also for if we get sick. And so it's one of the reasons I'm spending my time on weekends and during the days trying to be physically fit. Those who know me know I don't sit still for too long. And I'm really trying very hard because if I get sick, I want my lungs to be as strong as I possibly can to fight this virus. Unfortunately, COVID-19 loves to get into the lungs. And if you start off with poor lung function, you're in trouble. So you just showed Paul that if you have restrictive lung disease because you're overweight, or you have obstructive lung disease because you smoke too much, now you get pneumonia or COVID-19, you're more likely to go on a respirator and you may never come off. So to me, this is a great opportunity to get fit, to get fitter. And you can easily train yourself and increase your horsepower or your MET by about 2 absolute units. And that gives you a greater feeling of euphoria, feeling better, you feel better about the world. And if you do get sick, you have a better fighting chance. So everybody should know how many METs they can do. Lance Armstrong can do just under 30, but he cheats. And if you can do over 12, you're in great shape. If you're doing less than 5, you got to get fitter.
Wonderful. Thank you, Dr. Grenier. And here I'm going to show a few things that we look for on a stress test. A stress test is a very wonderful, it's sort of like a step up from ECGs as well, given that there is the exertion aspect of it too. So one thing that we look for is ischemia. As I mentioned before, ischemia tells us about potential areas of damage in your heart and areas of atherosclerosis. So that is going to be given by the ECG on your stress test. We also are going to ask if you felt any symptoms. Did you notice any chest pain? Because once more, this is going to tell us a little bit about some investigations and damage to the heart. If you notice some severe shortness of breath during your stress test, this could indicate that there might be something wrong with the blood flow to the lungs. So there is a direct connection from your heart to your lungs in terms of blood flow. And so if you have severe shortness of breath while you're exerting yourself and it's to the point where you have to stop the test because of your shortness of breath very early on, then perhaps that's one area of investigation as well. Irregular heartbeats. So Rachel talked a lot about palpitations, and we can hopefully look for these on the stress test as well. Exertion can induce palpitations too. So perhaps, instead of just feeling palpitations at rest, like a Holter monitor might catch, a stress test might might catch exertional palpitations that you find while you're sprinting on a treadmill. And finally, dizziness and lightheadedness. And so this can indicate perhaps some sort of issue with blood pressure. And, obviously when you're working out, you are going to feel, while working out, your blood pressure should go up. But a lot of us might end up experiencing a random drop, or not a lot of us, but rarely we might end up experiencing a random drop in blood pressure. And this can even lead to things such as fainting as well. So these are all things that we look for while doing the stress test. However, stress tests aren't necessarily the end-all be-all. It gives us a good baseline, and we end up doing further investigation as well, such as things like angiograms that Rachel's going to talk about too.
So just to go backtrack there about your stress test there. So first of all, this is Louis over here who's just barking for you. Get a dog, take your dog out for a walk, get yourself fitter. Blood pressure should go up with activity. And so if you have a severe narrowing of your blood vessels or your aortic valve, for instance, the blood pressure may fall. You might get dizzy, so blood pressure response. Or if your blood pressure is too high, it goes too high during the treadmill. It gives us some clues. Is my shortness of breath, well, I'm just deconditioned, out of shape, or am I actually getting lack of blood supply when there's EKG changes that are taking place? So very important. One thing I always remind you is that classic blocked arteries is called angina. Doctor, it's not a pain, it's a tightness. It's a sense of weight or a pressure sensation that comes on with activity, goes away with rest or nitroglycerin that lasts from about 30 seconds to 10 minutes. So we may reproduce that during your treadmill test. So that's a classic heart pain. But we all know that nothing presents totally classic. There's multiple presentations of COVID-19, from asymptomatic to shortness of breath to pneumonia to loss of smell and taste, etc. So many manifestations of heart disease as well, and the stress test does give us a lot of great looks at that. So thank you, Paul, for sharing that.
Right. And so
but get a dog.
Get a dog. I would love a dog as well. But so stress tests are normally safe. However, I do often hear of a lot of patients expressing concerns about a stress test, and they often ask a lot of questions going into a stress test as well. But they are normally safe. They take place in a controlled clinical environment. So there's a big difference between running in a clinic versus running alone on the side of the street. At least you have people around you who are trained in responding to anything that might go on. And we also have an ECG on you that's monitoring you while you are exerting yourself as well. But there are some risks associated with stress tests. For example, hypotension, like Dr. Cooney mentioned, you might experience a drop in blood pressure, commonly after exercising as well, and this could lead to a little bit of lightheadedness. Arrhythmia, so like I mentioned, sometimes palpitations might be induced by exertion. So, while this is a risk, it's also a good thing that we are catching this on an ECG. And finally, very, very, very rarely, stress tests might induce heart attacks. However, chances are, if a stress test induces a heart attack, it's because there was already very severe blockage and that heart attack was just waiting to happen anyways. So it's probably better for that heart attack to happen in the clinic, again, in a controlled clinical environment, than at home, because there are people there who can respond to that as well. And there are some other types of stress tests. Rachel's going to talk a little bit more about some of these too, but a stage one is a stress test with a spirometry. So if you remember, spirometry is measuring your lungs and your breathing. So stage one is stress test while having a spirometry. We have nuclear MIBI that Rachel's going to talk about, and that's more detailed and accurate stress test that injects dye to check the flow of blood, perfusion. And the stress echo combines the stress test that I just talked about with the echo that Tanya talked about. And it looks at an echocardiogram while the heart is under stress too. So I'm going to pass it over to Rachel to talk about the MIBI and the angiogram.
The risk of dying from a stress test is 1 in 10,000. So it does have a small degree of risk. As you say, Paul, I'd rather have my stress test in my doctor's office where we can actually diagnose and make the right diagnosis and get the right treatments. So it is a relatively safe test done in the appropriate environment and from the right people. People who we don't want to do a stress test is you had a heart attack today, you're very unstable, your heart's acting up. We're not too interested in doing a stress test in those circumstances. On the other hand, if we're not sure if your discomfort is coming from your heart or not, we have to go ahead and find out, and the stress test is one way of finding that out.
Okay. So I was going to talk a little bit about the nuclear stress test. So there are many different types of stress tests. So there's the ECG stress test, where Paul talked about. It's more of the baseline stress test, where you have an ECG attached to you. And what that test is mainly the electrical activity of your heart when it's under stress. The stress echo, which is a normal stress test where you run on the treadmill with your ECG, and then right after you get put on the bed and a technician starts doing an ultrasound on your heart. This specifically looks at the structural functionality of your heart when it's under stress. And what I'm going to talk about, the nuclear stress test, it's when you still go on the treadmill with an ECG, but you get a nuclear molecule that's injected into you. And at the end, you will go under a machine where it will scan the nuclear molecule that is in your heart muscles. And what that test specifically looks at, it looks at the perfusion of the heart muscles while it's under stress. So there are different stress tests, and not necessarily one is better than the other, because they all look at different things. And your doctor would know best on which stress test would be most suitable in your case. And as Paul discussed, stress can be exercise-induced, where you go on the treadmill, or if you are greatly limited in your functionality, like if you have arthritis, or if you really cannot use the treadmill at all, you can use some drugs to simulate the stressed state to your heart. But always, I would try to exercise, go on the treadmill when you can, because as Paul mentioned, the stress test is a very good test to test your functionality. And your functionality, your capacity to function, is directly related to how well you can do, your prognosis, your mortality. So always try to exercise to stress your heart instead of using a drug. Okay. So not many of you may have heard about the nuclear stress test. It's not as commonly seen or done compared to the ECG stress test. It is also quite a bit longer than the normal stress test. The normal stress test usually takes around 30 to 45 minutes, whereas the nuclear stress test can take around 2 to 3 hours that you'll have to block out of your day. So what happens is that you will start at rest. Before you will wait at the clinic, and then while you're at rest, you'll have a nuclear radioactive tracer delivered into your blood via an intravenous route, so in a needle. And then you will get a scan when you did not exercise at all. So no stress scan. And that scan is what you see at the bottom right, where the radioactive tracer is being imaged, and you see the perfusion of the heart muscles. The circle is the heart wall, and inside is the heart lumen. So right now you can see that it's quite well distributed, the color of the radioactive tracer. That means it's a good and well perfused heart muscle. And then what happens is that you will get prepared for an actual stress test where they'll attach an IV to you as well as the ECG, such as a normal stress test. Then you begin walking on the treadmill. Your vitals are being recorded just like a normal stress test, and at or near your maximum heart rate, they will instruct you to say, I can't go on anymore, about 1 minute before you actually can't go on anymore. So when you near your maximum heart rate, they will inject another dose of radioactive tracer into you. And then after your stress test, you take a little bit of a break. And then after your little break, you get scanned again. And the second scan tells us how much your heart can perfuse itself when your heart is actually under stress. And that is the image on the top right corner that you can see. So this is the stress imaging, where it's no longer well perfused. And you can see there's a little bit area of the heart wall that's thinned out. That means blood isn't getting to that area when you're exercising. And that indicates to us there probably is some sort of blockage in your heart blood vessels. So that's what the doctors look at when we do a nuclear stress test. Next slide. We'll move on to angiography or angioplasty. This is the gold standard for checking or treating blockages in your heart vessels. It will give you a very definitive diagnosis, and if they find anything that seems to be a blockage, then they can treat it right there and then when they do the angiogram, instead of waiting for you to come back and then make you take new medications or they have to go back in again. It's different from all the other tests in that we can treat it right there and then. Okay, next slide. So what is an angiogram and what is an angioplasty? They're very different things, and it's important to know the difference, especially when you're signing that consent form before you do one. So an angiogram or an angiography is an imaging test. It's a diagnostic test where they inject dye into your heart vessels to visualize the anatomy of your heart blood vessels. This is the most accurate test there is to evaluate coronary artery disease. And this is only taking a picture. It's not doing anything. It'll see if you have blockages, but it doesn't do anything. This angioplasty, or we often refer to it as PCI, standing for percutaneous intervention. It is an interventional, it's a procedure where if we see a blocked vessel, we will open it using a catheter, balloon, or a stent. So these two are very different in that one is diagnostic and one is interventional, although they can often be done at the same time. So although we said that angiogram is the gold standard in diagnosing coronary artery disease, gold standard doesn't mean it's the best test for you. Every accuracy with a certain test will come with associated risks. For example, we know that an ECG is probably less risk than a stress test, but an ECG is much less effective at diagnosing coronary artery disease than a stress test. But also when you have a stress test, even though you can get a better diagnosis, you're also more at risk. You can get hypotension, you can get maybe a myocardial infarction, and you can get dizzy. Whereas if you just have an ECG, there's no risk to you, but also there's less information that we can get. So the same with an angiogram. It is the gold standard because it gives us the most information, but at the same time, it is also the most invasive and the most risky because basically for anyone who undergoes an angiogram, there is an estimated risk of 1 in 1,000 where you can have a stroke that causes permanent damage and permanent paralysis to you when you have the angiogram. And this is one of the major reasons why cardiologists don't put everyone on angiograms. Because if there is no risk, every cardiologist would like to find out exactly what's going on with your heart. But we can't because it carries a certain kind of risk. And when you have hypertension, when you have diabetes, when you have a heart failure, or when you have renal disease, that 1 in 1,000 will go much higher for you. So this is the base risk for having an angiogram. There is even more risk if you do an angioplasty because now you're actually doing something in the heart vessels, and that carries its own risk because you're disturbing the anatomy of your heart. So next slide. I guess it's not. Is that the next slide? Okay. So when we have an angioplasty or a PCI, we're opening up vessels. But is that always the best thing to do? Now, as human instinct, when we have a blocked blood vessel, the natural intuition is, okay, let's open it up. Let's make sure our heart can get enough blood. And for a very long time, doctors thought the same. They thought that if you open up the vessels, it's good for the heart and it'll make you live longer, it'll make you have less chest pain, and they're only partially right. Opening up vessels does not necessarily make you live longer, except under circumstances. PCI or angioplasty for sure will make you live longer if you are having a heart attack right now, because that blockage is killing you. And by opening that blockage, you can prolong life and you can restore blood flow to the blood. But if you're just having some angina, you just have your chest pain here and there when you climb upstairs or when you're lifting heavy stuff, and you go in there and you open the blood vessel, that doesn't necessarily make it better. And we'll go over some of the scientific studies that looked and compared compared no angioplasty to angioplasty and saw the different results. Okay, next slide. So this is a visual representation of what happens when you do an angioplasty. So you have on the left your narrowed blood vessel, and you insert a catheter in there. It's usually either through your arm or through your leg that will insert the catheter, and it'll go into your heart vessels, and it'll pass the narrow section and deposit a balloon to open it up and place in there a stent to keep it open when the catheter is gone. Now you realize that when we say open it up, we don't mean we're removing the blockage. We're just pushing it into the wall of the artery. It doesn't remove any plaque that you have. It just pushes it into the muscular walls. So a stent or a PCI, it does not cure heart disease. You might not feel chest pains anymore after you have a PCI, but that doesn't mean you don't have heart disease anymore. You still have heart disease. You still have plaques in your heart and the rest of your body. All a stent does is that it sweeps the plaque under the rug so that you don't notice it as much. But if you don't control your risk factors with medication, with lifestyle modifications, that plaque progression is still going to happen. Okay, so I have two trials that I wanted to introduce you to. A trial is basically when scientists gather a lot of people and they divide them into groups of different treatments. So in this trial, it's called the MASS2 trial. It rounded up around 600 individuals. All of them have multi-vessel heart disease, meaning that more than one vessel, often 3 vessels in their heart, are blocked. And of those 600 individuals, they divided them into approximately equal 3 groups. One group had only medications to control their heart disease. Another group had medications and angioplasty. So they put a stent in them, or they opened up their arteries with a balloon and then controlled the rest with medications. The third group had medications and bypass surgery to fix their heart disease. And now let's see how these 3 groups did. And next slide. So this is a little bit of a busy slide, but I'll go over each line with you. So on the right, on the columns, I have the 3 groups. Group 1 is the group with only medications to control the heart disease. Group 2 has medications and an angioplasty. And group 3 has medications and a bypass surgery. So first we looked at whether their blood vessels got clogged again after when we evaluated them. So after their PCI, after their bypass surgery, did their blood vessels get clogged again where we need to go in again and reopen it? That's what they were looking at. And it seems that for when you're just on medications or when you had medications and angioplasty, your blood vessels got clogged again after 1 year. Compared to if you had a bypass, almost no one had to go back in and reopen up vessels. So do PCI or angioplasties help keep vessels open? Based on this study, not necessarily. But what PCI is good for is if you look at the second row, it says angina-free after 1 year. This is it basically means how many people no longer have chest pains after they either had medications or had PCI or had bypass surgery. So among those people who only have medications, only 36% of people no longer have chest pains. The others still have chest pains on a regular basis. But for PCI and bypass, around 50 to 60% of people no longer experience chest pains, which is good. If the chest pains are bothering you a lot, or you feel like your chest pain is getting intolerable, then PCI or a bypass surgery may be an option for you. But if your chest pain isn't really bothering you, and you're just trying to open up vessels, then it shows that an angioplasty may not be the best option. So this is after 1 year. 1 year is not a really long time in terms of heart disease. You don't want to take a medication that tells you, okay, you're going to be fine for 1 year, but then after 1 year, everything's going to go downhill. So we want to be looking at interventions or medications for a long period of time to see if there's any long-term effects. So this study followed the participants for 10 years. So after 10 years, the survival rate of the participants for each group is around the same. There's no significant difference. There's no statistical significant difference among the three groups. So does an angioplasty, does opening up vessels make you live longer? Based on this study, at least for the 10 years, no. And in 10 years, are there more blood vessels that need to be opened? Is the disease progressing? And for medications and PCI, yes. They still needed to go back to the surgery room or go back to the catheter room to reopen up some blood vessels after they had the first PCI. But for the bypass surgery group, it was much less. Although people still needed to open up vessels because heart disease is a progressive disease, and it is natural to have progressively clogged arteries as you age. And what about angina-free after 10 years? It seems to be there seems to be a difference between if you just take medications or if you have an angioplasty, because it seems that when you have an angioplasty, you have a bit more chance of not having chest pains after 10 years. So this is one trial. And based on this, I've highlighted in green the advantages that may be associated with each intervention, where PCI, although it doesn't change mortality or progression of disease, it can help improve your symptoms. And that is one of the major reasons why someone with stable angina disease may choose to go and have this intervention done, even with its risks. Next slide, please.
That's really important concept, is that the procedures make you feel better. They sweep the problem under the rug, but they don't make you live longer. And that's a concept that's really hard for people to understand. And but that's well done.
Thank you. Okay, so the next slide has some similar concepts that I just like to reinforce. It's called the COURAGE trial. This was done in 2004, and this had more people. So this had 2,287 individuals with stable coronary artery disease. This means they just have angina with predictable chest pain upon exertion, but that usually resolves by itself. So they divided these people into two groups, each one approximately the same number of individuals. And again, it was medications only to control your angina, or it was medications plus opening up the vessels with PCI to control the angina. So they looked at mortality and non-fatal MIs. After 4.6 years, after either just medications or PCI and medications, they looked at how many people died, and there was no difference. It didn't matter if you opened up the arteries or not. After 4.6 years, everyone had the same mortality. So PCI does not make you live longer. However, after 4.6 years, they also looked at, again, whether you needed to go back into the catheter room or go back into the surgery room and reopen up arteries. And it seems that when you have a PCI, you seem to have more incidences. You have a higher chance of those arteries getting blocked again, where you need to reopen it up. Whereas if you just take medications, you don't seem to have as many incidences of having to reopen arteries or having to reopen up arteries. Now, this is what we're all looking at, the symptoms, because on the last slide, I did say that PCI helps improve your symptoms, and that's one of the major reasons why people do it. So they looked at angina-free people, angina-free after 1 year, and as expected, PCI, where you open up the vessels, helped people experience less symptoms, where there are more percentage of individuals who were angina-free with no chest pains. However, after 5 years, the number of people or the percentage of individuals in each group who did not have chest pain seemed to be around the same between the medications group and the PCI group. So yes, PCI can reduce symptoms, but we're actually not sure how long that advantage can last. So you might have no chest pain for 1 year, you might have no chest pains for 5 years. The doctor cannot really predict how long the effects of a PCI is going to last. So these are just some of the things that a doctor needs to consider and that he would need to discuss with the patient before undergoing an intervention or an invasive test such as an angiogram or an angioplasty. And we really need to weigh the pros and cons before we undergo a test that carries significant risks like strokes, like bleeding, like myocardial infarctions while you're on the table. Okay, next slide. I think that's the last. Oh, okay. So after I talked about all the pros and cons, perhaps it is helpful to just summarize at the end exactly why doctors then do angiograms or why do they do angioplasties if they only improve symptoms and they carry around so much risk. One of the major reasons, the number one reason to use an angioplasty or to do an angiogram is if someone comes to the hospital and they look like they're having a heart attack. This is one of the first things, well, other than taking an ECG and a troponin blood test, is they will be shipped to a cath lab, a catheter lab, where they will have an angiogram done and an angioplasty done if they find a blockage. Because that person who's having a heart attack, if they don't get the blood vessel open, they will die. So this is the number one reason to use an angioplasty, because it saves lives, literally. Other reasons when a doctor may choose to use an angiogram or an angioplasty include 1, to relieve angina symptoms, as we talked about, or 2, to find out if you have heart disease. So as I said, the angiogram is a gold standard for diagnosing coronary artery disease. If you have gone through stress tests, you've gone through echoes, and the doctor still has no idea why you're having angina symptoms, that may be a reason for him to refer you to an angiogram just to find out exactly what is wrong and whether whether you have heart disease or not, so he can actually treat you. Another reason, one of the last reasons, another reason to do an angiogram or an angioplasty is if you have a high risk anatomy or a high risk heart disease. So both of the trials that I just talked about, the background is stable heart disease, and that's a key word. Stable angina, when you do an angioplasty, can help improve your symptoms and it doesn't change your mortality. However, there are certain heart diseases that are much higher risk. It also depends on exactly where the clot is. If the clot is in, let's say, a left main disease, is where it's in a very critical part of the heart, and you're at much higher risk of having a heart attack or sudden death, that's when an angioplasty will improve your survival. But for stable heart disease, usually it does not make a difference in your mortality or your survival. Okay, I think that was the end. Yeah.
So that's actually just to pause for a second. So what we're saying is the best time to have a wire in your heart is when you're having a heart attack. It means
Yes.
the artery is totally blocked or occluded, and you've lost that battle, the artery is closed. That is for sure an important moment. And so if you think you're having a heart attack, you call 911. And what's happened in many circumstances is that, well, that pain will go away, it's just my stomach, etc. Now people are afraid to go to the hospital because they're worried about, complications from COVID-19, which I understand. Paul, you showed a nice slide how labs have changed. Hospitals have changed as well. So if you think you might be having a heart attack, you take nitroglycerin and you chew an aspirin and you go to the hospital. You call 911. That's so important. Now,
Yeah.
for stable angina, just thinking if I just open the vessels, I'll live longer. And for the vast majority of people, you'll feel better, but you won't live longer. What makes you live longer is how to prevent the disease from getting worse. So I know you're in the future going to tell us about cholesterol management. That's why the most important drug I prescribe is called a statin. High-dose statin therapy and ezetimibe will decrease the chance of having a heart attack by 60% if you take it for 5 years or greater. Aspirin lowers the risk by about 10 to 15%. So I'm saying and lifestyle changes are so important. And yet, let's just give me the balloon. Well, let's use the balloon for the right time, the right purpose. But let's think about how we put this disease at bay and at rest. So I guess one analogy is I can isolate myself and not get COVID-19, or I can live in this world and make myself healthier and not get COVID-19, make my lungs healthier. If I smoke, stop. It's bad for the heart. Paul, you said you lose 5 minutes of life every time you have a cigarette. That's true. Knowing your risk, you just showed us that you can get your blood work done, and we can know results. So this is wonderful. So you want to make sure you're treating the right disease, and that's why we make these diagnoses. That's why we look at the echo to see if there's been heart damage. We do the stress test to see the extent of the blockage formation, where that pain is coming from your heart. We do the monitors to make sure you don't have a bad fatal rhythm that either can cause a stroke called atrial fibrillation or cause ventricular tachycardia that can actually kill you. So there are so many things, but the basic is prevention. That's the key. And you guys did such a wonderful job explaining all these tests. And in fact, I thank you so much for showing that. Paul, you're now going to join the privilege to help, and you're going to join Rachel, who's you're ahead of you. Tanya, you're just a year behind. You guys have done such a wonderful job helping all of us, and thank you. Let's get some discussion going. Any questions or thoughts from everybody? Wonderful job. Thank you. Any other comments from Tanya? Do you have any thoughts at all? Paul, Rachel, what are your thoughts?
Any questions or comments from the audience first? Again, you can just use the YouTube chat box or unmute yourself from WebEx. Everyone will be muted if you do have a talk.
I've got one. It's Mike.
Yeah.
So if you have a MET test that's low, I just had a stress test, let's say. I don't know nothing about MET until tonight. If I had a low number in my stress test, you would have told me that probably, right, doctor?
Well, no news is no news. So
Okay.
one of the things I'm trying to empower you is to understand numbers. Now, one of the things I'm sometimes fearful is that if I give you information and that will motivate you to do better, terrific. If I give you information that will terrify you, I will kill you. And I'm not interested in I'm trying to make you better, more resilient, and healthier. So I make a judgment call. Some people I will tell brutally everything, and some people I will just tell them what I think that they want to know. And I'm not trying to,
I understand.
I'm trying to do the right thing for the right person, and so everybody's a little bit different. And what should be your MET load compared to somebody else's and things of that nature. There's Philip there, who did some special testing. He was having some angina. He's had angina for a long time, and we ended up doing a nuclear medicine study to show that his amount of heart tissue at risk is not so high, and so we can treat with medically, and he feels better by knowing. He's also going back on his bike and his walks and things of that nature. I'm going to go out there and do my best to be as healthy for as long as I can. So METs is one measurement done. Now, I know that Lily sometimes, she's had enough. She wants to get you off the treadmill because the people that tend to die are people when you overexert yourself. So we have to find that balance. Yes, you can go a little bit further. So we're just making sure that the heart's getting good blood supply under circumstances and how we react to that. But it's a great question. So knowing your METs is a really, really important thing to do. I hear someone said they can do 15 METs over there. And it reminds me of one of the first time we had our first treadmill. We had a competition who can do the most. There was this young, fit kinesiology person said, "I can do more than you, Dr. Kern." You said, "Sure, I'm sure you could." And so she went first. So always give yourself the advantage of being last. And there's also one way of cheating a little bit on the stress test by holding tighter on the bars and taking longer steps and being more efficient. So she thought she did really well. I did quite a bit better.
Are you only saying this because she's not here right now?
That's right. But to be fit, you have to work at it. And my wife is fitter than I am, and I'm trying to catch up to her. And so I'm working. We're all getting better, and we're also having fun doing this. So MET is, and I think most of us can get fitter and make ourselves healthier, our quality of life better. You mentioned, Paul, that when you watch too much TV, you hear too much about the news, it gets depressing. I listen to the news, but I also find I get depressed as I listen to it too long. So I go out for a bike ride, go out for a walk, take the dog out or something, and it's important. I'm still not as fit as I want to be. I'm still not as healthy as I want to be, but I'm getting better. And you guys all made that easier. So we can all just do it together. Other questions? Someone was just bragging there about doing 15 METs. Good for you.
That's Dr. Phil. Yeah.
And it's us old guys and ladies that are doing pretty well. We're just old and steady, right, Phil?
All right.
Are there any other thoughts from anyone?
Yeah. I guess I just also want to emphasize one more time. I'm looking at the time now and just realized, the time flew by in front of our eyes. It's 2 hours and 20-ish minutes. So, again, this is going to be recorded on YouTube. So if anyone does need to look back, I know all of us are going to need to look back at some point. And, don't hesitate. Like Dr. Kearney said, I'm similar to Dr. Kearney where I have to watch something many times for it to really stick. So take advantage of the technology.
Yeah.
Wonderful review. And I think that should be shown a great tool for patients and people with disease, and be great to spread that around Ontario and Canada, your video tonight. Save us a lot of time, family medicine, and maybe get more compliance. So good for you, Paul. Unbelievable, your knowledge, and same to you. Let's see, Rachel. Good for you,
and Tanya as well.
And Tanya there too.
And
Yeah.
Tanya, yeah. So congratulations. Congratulations on joining us in our career. It's a lifestyle. It's not a job. You'll see, but it's a great lifestyle.
Yeah.
So good for you getting into medicine. Congratulations.
Thank you. I'm really looking forward to that.
Well, I want to thank you all for attending, and lots to look at, lots to learn. 30 years later, I still got a lot more to learn, and we got another 20 more or 40 more years of learning ahead of us. So I want to wish you all a very safe evening, and get out there, be fit, know what's going on. What's next week's schedule, Paul?
Next week, we are still in the process of deciding. We might do DASH diet. And then the week after, we have Rachel Liu and Rachel Eo coming in for cholesterol in your diet as well.
This week, we got some bad news about what's happening in some of our nursing homes and how, and we'll have a little talk about that as time goes on. But to me, is that we need to become more health conscious. We all need to work harder at this, working together at this. So I'm going to bid everybody a good night. Tomorrow is an ECHO conference for those who want to learn more about ECHOs. There's more fitness and more eating. I had my dinner all day, and so I got to eat some blueberries, some quinoa. My wife made this walnut muffin of sorts, and this week Chad and I finished the course Forks Over Knives, and we'll talk more about that. But that's, you can cook without liquid fat, and you can cook really healthy. So be healthy, be wise, and have a great week. I think some of us are just going to stay on and have a little chat. I wish everybody a good night, and thank you, Paul, Tamia,